Right now, across the vast nation of India, approximately 150 million people are in need of active mental health intervention. To serve that population, the national health system makes a budgetary allocation of exactly 0.06% of the overall health budget. Mental health is intrinsically linked to physical outcomes. Untreated anxiety correlates directly with cardiovascular disease, while depression frequently coexists with cancer, delaying recovery for both. Recognizing this integration, the UN's Sustainable Development Goals mandate that nations address mental health and substance abuse as core components of non-communicable disease treatment. The math bears this out. Mental disorders account for 13% of total disability-adjusted life years lost globally, representing a severe and debilitating morbidity issue. This friction between disease burden and budget creates a massive treatment gap. That gap spans from 28% to an extreme 86%. Solving a crisis of this magnitude requires deconstructing the specific data to see exactly where the system fails. The most comprehensive roadmap of this crisis is the National Mental Health Survey of 2016. This data establishes a baseline current mental morbidity rate of 10.6% across the population, excluding tobacco use. Substance use disorders represent the single largest driver, affecting 22.4% of the population. Depression remains the leading common mental disorder at 2.7%, meaning 1 in every 40 adults is currently suffering. When filtered by age, the data shows that prevalence peaks in the 30 to 49 demographic. This demographic is the core economic engine of the country. These disorders directly impact national productivity and earning potential. Furthermore, this clinical burden is also heavily centralized. While rural areas show a prevalence of 6.9%, urban metros suffer at nearly double that rate, 13.5%. In these dense environments, severe disorders like psychoses and mood disorders are 2 to 3 times more prevalent than in rural areas. Mental illness in India is a targeted crisis, striking the most economically productive citizens in the most critical urban centers. We can track these 150 million individuals through a patient journey funnel, which reveals a massive drop-off caused by social stigma. This stigma acts as a severe sociological friction point, actively preventing these patients from even entering the healthcare pipeline. The numerical reality is stark. Nearly 80% of those suffering receive zero treatment, despite having an active illness for more than a year. This lack of care prevents individuals from working, educating themselves, or participating in family life, deepening the socioeconomic impact. Stigma is an active epidemiological barrier that prevents diagnosis and destroys inclusion before clinical care can even begin. On the supply side, the healthcare infrastructure itself faces a systemic failure. India's 0.06% budget allocation contrasts sharply with the 4% spent by most developed nations. This deficit results in a severe paucity of specialists, including psychiatrists, psychologists, and psychiatric social workers. These few professionals are also subject to extreme geographic maldistribution. Health workforce density varies wildly across states. Uttar Pradesh sits at a low baseline of 146 health workers for every 100,000 people. Kerala sits at the high end of the spectrum with a density of 995 per lakh. This inequity leaves massive segments of the population with zero specialist coverage. Even with stigma erased, the current specialist-driven architecture would immediately collapse under the weight of 150 million patients. Fixing this mathematical impossibility requires a systemic solution called task shifting. Task shifting actively moves primary screening and care away from scarce, expensive specialists to a broader network. The goal is to integrate mental health screening directly into general primary healthcare and existing NCD prevention programs. This new network relies on non-specialist grassroots functionaries, specifically ASHA and A&M workers. These workers conduct basic screenings during routine community activities, managing the referral pipeline to ensure continuity of care. Task shifting transforms mental health care into a resilient, distributed network capable of scaling to millions of people. The policy frameworks needed for this structural transition are beginning to take shape. Legislative milestones like the National Mental Health Policy and the Mental Health Bill of 2016 provide the necessary legal momentum. Strategic success now depends on an independent national commission to monitor and enforce data-driven programming across every district. Closing the 86% treatment gap is a structural engineering challenge. It requires moving mental health from the margins of the budget directly into the foundation of India's primary care system.